So I will be talking about the 1838 study, as you will know it. So this is where we dosed a large group of hypertensive patients and we almost completed the trial. It's been going on for the best part of 2 years, I think. And it's been a journey for all of us. But the exciting outcomes of these studies, I think, justify every bit of effort we put into this. Now, the presentation I show you is one I've given at the American Heart Association, so these slides are in the public domain. And I can, of course, also, because this data belongs to the sponsor company paying us to do this work, only show you those slides which are in the public domain, but I can explain a little bit on the background, or a little bit more in the background. So to start off, hypertension is and remains a leading cause of death. And I know we live in times of corona and we become all somewhat numbed up to large numbers of deaths, but there are a lot of people dying of hypertension. And it is, of course, a treatable disease, and it stands to reason that we treat it. But the problem, as you can see here, is that only really half of the patients diagnosed with hypertension are in fact receiving adequate treatment. And of those who do receive appropriate treatment, a fair proportion of them don't take their tablets. And of course, the reason why hypertension is such a silent killer is because we don't notice any symptoms. As we are diagnosed, we're not really bothered by it. And you might well be bothered by the fact that you have to take one or several tablets a day. You might experience the side effects. And for all of these reasons, a lot of people have hypertension. And whilst in itself is not really a problem, in fact, an increase in blood pressure is a normal physiological response to exercise and excitement. Probably my blood pressure is somewhat higher now. And however, if this happens at rest, then the heart is trying to pump against a greater resistance. You know that your vascular tree can essentially contract. And so the heart has to exert itself more in order to pump blood around. And of course, this is not really required by demand. And what it leads to is, of course, changes to your vascular bed. And that then, in the longer term, leads to heart attack, because heart attacks, stroke, heart failure, kidney disease, and ocular disease, where essentially people have visual disturbances or blindness. There is quite a large number of agents around, but to cut a long story short, no single agent usually treats the condition well enough, so that the standard approach nowadays is that you would combine usually something which affects the renin-angiotensin-aldosterone system with a blocker of sorts, so a beta blocker or calcium antagonist. And of course, I mentioned compliance. You also try to administer in such a way that it interferes with people's life as little as possible. And over time, we have learned that even small changes or small blood pressure changes are in fact harmful and lead to adverse outcomes. So the targets we now have to treat hypertension are fairly low. So anything above 130 over 80 is in fact regarded as a treatable condition. And if you take this into account, then 1 in 3 people in this country has hypertension. 1 in 3. Now, as we have Professor McLean here today, who's an old colleague of Brian Pritchard, and Brian Pritchard is one of the pioneers in this field, I thought I'd briefly talk about my experience training with him for well over 10 years. Brian Pritchard published a paper back in 1968 finding that beta blockers lower blood pressure. And that at the time was regarded as an adverse side effect because the beta blockers were developed to treat angina and not hypertension. And there was, I think, a fair amount of pushback at the time, fearing all sorts of negative outcomes from the drug company's perspective. But Professor Pritchard prevailed, and he managed to convince the fairly skeptical medical community that lowering blood pressure with the use of beta blockers was a useful thing to do. And if you bear in mind that we normally just treat people with symptoms, in other words, they come to the doctor because they have a problem, here we are treating something that we know will lead to a problem, but acutely doesn't. And of course, that was a fairly novel concept in these times. So in a way, Professor Pritchard is a pioneer of preventative medicine. And he served on our board from 2001 and 2010. Now, ALN-AGT, or silibisiran as it is now called, it works on the RAS system, the renin-angiotensin-aldosterone system. And the vasoactive substance, the hormone, is angiotensin II, which has several effects which all lead to a rise in blood pressure. The precursors of that are made in the liver, that's angiotensin I and angiotensinogen. So the small interfering RNA we are discussing is targeting angiotensinogen, so it's taken away the building block of the hormone. And the way it works is you have an RNA, and of course administering RNAs, as Julian has already alluded to, is a tricky thing, because if you just inject them, we have nucleases that break them up immediately because we used to defend ourselves against foreign RNA and DNA material. So in order to deliver it, you need to come up with a mechanism whereby it gets to the cells where it is meant to go quickly, gets inoculated very quickly, and then exerts its effect locally. And the way Alnylam has solved this problem in 2 steps. In the second step, they've attached a GalNAc sugar, therefore it's also called GalNAc substitution, to the RNA material, and that is then taken up by the GalNAc receptor, which is in humans only present in the liver. So it is very tightly targeted to the liver. It's taken up in the liver where the angiotensinogen is made, so it gets to the right cells. Once it is taken up, it then is in the cytoplasm of the cell. It does not enter the cell nucleus. It effectively tricks the body into believing that the messenger RNA, which codes the production of angiotensinogen, gets broken up. And that then leads to the reduction of the messenger RNA, and then we no longer make that protein, and therefore the cell can no longer expel angiotensinogen. That's the principle behind it. The automedicines, which are, one of which is patisiran, they have a liponanoparticle core around the RNA material, but the disadvantage of that technology is you need to give it intravenously, and you have to give it very often. And that's not really an option for hypertension treatment. The study we've done, as you know, had multiple parts. The first part was a single ascending dose study. And again, I want to point out to you that this is something unusual to do. Most drug developers in the past, you would have tested the compound in healthy volunteers first. Here we go straight into patients. And one of the reasons why we're confident doing that is because we now have a reasonably good understanding what these small interfering RNAs do. And also, most of the hypertensive we recruited in the trial, they're in a pretty good shape. So in a sense, if they're happy to volunteer, then that is a very feasible approach. Now, we went up in 7 dose levels. The starting dose was 10 milligram, and the highest dose we've given is 80-fold that, it's 800 milligrams. And as is the case for all first-in-human studies with the dose escalation, we looked at all the data in interim steps. So this is why it took us a year in order to run this study. Now, importantly, as you know, whether or not a particular agent in the treatment of hypertension works in individuals is also dependent on origin. So RAS blockers don't tend to work in people of African descent very well. But we nevertheless wanted to include patients because, of course, you never know. This is an early experimental study. You look primarily at tolerability and knockdown. And of course, this is an opportunity to study this subgroup as well. Now, these are the results, which very much mimics what Julian has just talked about. The top line is the placebo group, and as you can see, the amount of angiotensinogen we measure in the plasma stays fairly constant. We don't really know why there is a significant increase, albeit it is small, but it is 10%. This might well be because we have been washing out these patients of their medicines. And for all treatments, you see a significant knockdown of the angiotensinogen. And I can only confirm what Julian has said. We do believe that there is a dependency on knockdown to the efficacy of the agent we are using. So we're aiming for a near complete knockdown of liver-produced angiotensinogen. And as you can see, the 800 milligram dose is at the very bottom of this graph. And you can also see that at week 24, so that is 6 months after one single injection, we still have this degree of knockdown. So it's basically gone. And that, in fact, connects very nicely to the blood pressure effects. So these graphs show you the blood pressure response at 8 weeks, 12 weeks, and 24 weeks, i.e. 6 months. And the 200, 400, and 800 milligram doses were all effective in the sense that we had a blood pressure reduction of the systolic blood pressure of at least 10 millimeters of mercury in all of these dose groups. And you can see that with the 800 milligram dose, we look at 20 millimeters of mercury. And those of you who know how to treat hypertension, you will agree with me that it's an enormous reduction, and it's consistent, and it would theoretically mean that we can overcome all the compliance problems treating hypertensive patients, because this is a subcutaneous injection which they can have at their pharmacy once every 6 months, and this will, in many of them, sort out their blood pressure problems. In terms of safety and tolerability, occasionally with subcutaneous injections you do get local skin reactions, and we've seen some of that. But of course, since this drug works through the liver, the main concern is always that you have some degree of liver toxicity, but we don't. And as you can see on this, the various dosing groups and the placebo group, there is really nothing exciting happening by way of side effects. You might also know that we measured continuous blood pressure. So the patients have the blood pressure monitor attached to their arm, and the device then takes 3 measurements per hour typically. And this allows you to look at the diurnal variability of blood pressure, and you can see that during the daytime the blood pressure is obviously higher, and at nighttime it is lower. Now, there's a lot to be said about this, because obviously not every hypertensive patient does have this recovery period during the night. And if you bear in mind that these patients continuously damage their vascular system by high blood pressures, then if they're not dippers, as we call them, they have a far greater problem even than those who dip at night. But again, you can see here that the 2 placebo and treatment arm are clearly distinct. So even in this small first-in-human study, which is not really intended to show efficacy or prove it, we can already say this is a close and shut case. We know this works. We know it has very few side effects. And I'm so excited. I'm just as excited as Julian is about it. We then did a couple of things which I thought were rather clever. So we wanted to know whether or not there would be an interaction between a low sodium, a low salt diet, and a high salt diet, and what is effectively a RAS blocker, because theoretically they work in the same manner, reducing blood pressure, and potentially all of these treatments could, of course, do too much and lead to hypertension. So that was the concern, and this is why we did this experiment. So we brought in the patients for 1 week of a low-salt diet. I'm not sure how much they liked the food, but it contained really very little salt. And we then gave them for 1 week salt tablets, which essentially ensures that the RAS system is saturated. We then measured the blood pressure data during these periods, then dosed them with zilebesiran, all placebo. 8 of them received the active drug and 4 received placebo. And then 6 weeks later, when the effect of zilebesiran takes hold, we repeated the low salt, high salt experiment. And this is the data. So, as you would expect, when the patients are on a low salt diet, this reduces the circulating volume, that reduces cardiac output, and therefore you have a nice blood pressure reduction. And of course, many of you will know that the first line of treatment, of course, in any newly diagnosed hypertensive patients is, of course, to recommend dietary changes, to stop smoking, drinking alcohol. All of these things people also are not very adherent to. But we know that it is pretty effective in lowering mild hypertension. And that's what we see here. And you can also see that the placebo arm and the treatment arm, although they had a different starting point, the degree of reduction is the same. And you can also see that if you return them back to their salt diet, that their blood pressure goes up to what it was. And here's the results you see when they are treated. So again, this is the placebo arm, and if you compare the effect of a low-salt diet before and after the placebo dose, you can see it's very reproducible. And that's remarkable because this is a very small study, so you've done a really good job in actually depicting that. And as far as the interaction between zilebesiran and the low-salt diet is concerned, you can see that you get a further reduction in blood pressure, which is great. So if people diet and take zilebesiran, they can expect a pretty good blood pressure control. And if you then put them on a high-salt diet, the effect is basically cancelled out. And the usefulness of that experiment is that, of course, it gives us an opportunity to treat those who have too much of a reduction and are hypertensive and have orthostatic problems. It means simply by giving them a few salt tablets, we can rectify that problem. That's also very helpful. Nothing much on the adverse events. And the second experiment we did was to look at the interaction between irbesartan, which is an angiotensinogen receptor blocker. So if you do make some angiotensin II, even with the reduced amount of angiotensinogen, you have to do that, then what is the interaction with the inhibition blockage of the receptor it works on? And for that, we randomized 12 patients, and then, or 16 actually, and if we then followed the response to zilebesiran, and those who had a significant reduction in their blood pressure from baseline and blood pressures below 120, we kept them on a placebo tablet, and those who had a higher blood pressure, we added the irbesartan. And this one isn't a graph, I'm sorry about that. But you can see that zilebesiran in the cohort that has a good effect, the blood pressure reduction is what you've seen before, about 20 millimeters of mercury. And after the placebo dosing, this blood pressure reduction is the same as you would expect. Now, those people where we could give irbesartan because the response wasn't so great, you can see that they only had a mean reduction of 7.7 millimeters of mercury, so not great. But if we then add the angiotensin blocker, we get a further reduction of 6.4, so the combined effect is about 14 millimeters of mercury. So it's not as good as those who have a very good response, but it's still, of course, a very meaningful, clinically meaningful blood pressure reduction. And of course, that was one of the reasons why I asked Julian about individual responses, etc., because it is, of course, a problem in prescribing these drugs in the longer term. Now, one of the contributions you've made, and I thank you for that, is that the data management group and the study management group, you've done a fantastic job really in allowing us to include as many as 99 patients in this trial that recruited 120 in total. Now, having this many patients to supervise is a challenge, and it was really Dill's group that developed a tool which allows us to monitor each individual patient's blood pressure on an almost daily basis. And because you can imagine if you wash out people from their medication, there is concern that they are left hypertensive for a long time. These studies take 6 months, so you don't really want to deprive someone of a necessary medication for that long. And these sort of tools, I think, will make a big difference in what we can offer in terms of running clinical trials to the industry in the longer run. And this is just another example. This is the IONUS study. So here we are concerned about a fall in thrombocyte count. So we can look at each individual patient and monitor the thrombocytes, so we know we're not doing any harm. We also now have a pharmacovigilance group, which is headed by Pooja, which is a great improvement because it allows us to manage the many serious adverse events, which of course we as an organization weren't accustomed to. If you run a healthy volunteer study, if you ever see a serious adverse event, you can easily handle this. We were completely swamped. And of course, it is important to communicate with the company swiftly over these serious adverse events and provide all the information. And so we had to learn this from scratch. And I'm really very thankful to all of you as a team helping us to achieve this. I'm not going to bore you with the conclusions again. Essentially, it is a jolly good potential treatment for hypertension. The reductions are really very meaningful, and the prospect of possibly giving this once every 6 months without really any serious side effects to worry about is some fantastic news. Because what it means for someone diagnosed with hypertension at the age of 40 is that in the worst case they look at something like 80 injections in their lifetime, which is something a diabetic patient runs up to in 2 to 3 months comfortably. So it's great news. And with that, I'd like to mention that, of course, we are very thankful to the patients who participated in this. I'm very thankful to the team who helped us doing this. I'm hugely grateful to Alnylam to offer us the opportunity to run this study and give us a relatively free rein in the way we run this study, which allowed us to recruit 99 out of 120 patients. And hopefully we see the last patient completing the trial. There's a lot of data. This is interim data. And our group has generated a lot of interesting exploratory data, which we all hope to publish over time. So thanks a lot.